everyone. My name is Aminat Akib. I am a third year medical student at the Howard University, and I have the pleasure of serving as the Anesthesia SIG liaison for this academic year. I want to welcome you all to the start of the Anesthesia Specialty Series. This series is part of our Sowing Seeds program created by our national president, Ososi Obo, in collaboration with the Alumni and Multicultural Affairs National Committee, and continued on with our current national president, Nita. Throughout this year-long program, we'll provide resources on how to succeed as a pre-med and medical student, and we'll touch on everything from financial literacy to preparing for board exams and more. So make sure you're a national member by visiting snma.org and signing up to stay in the know. Right now, I'll also like to introduce our amazing panelists. I'll first like to start off by introducing Dr. Alicia Peterson.
Hi.
Dr. Peterson is a triple board certified anesthesiologist and the current director of chronic pain at Children's National. He also has the pleasure of serving as assistant professor at GW University here in Washington, D.C. The next panelist I'd like to introduce is Dr. Michelle Sumler. Dr. Sumler is the program director of ACTF and simulation and also an associate professor at Emory University in Atlanta, Georgia. The next panelist I'll have the pleasure of introducing is Dr. Stephen Bradley. He's a current critical care medicine anesthesia fellow at the University of Chicago. I also have the pleasure of introducing Dr. Jessica Boateng, who's currently a pediatric anesthesia fellow at the University of Pittsburgh Medical Center. Thank you guys so much for joining us today. So as we begin, I want to like to start off by asking each of the panelists to kind of walk us through their journey through medicine by telling us where you trained for medical school, where you completed your residency, and where you are now. In addition to that, I'd also like for you to tell us, why did you choose the field of anesthesia, if you had any mentors in the field, and end it with your favorite thing that you love about the field of anesthesia. We can start with Dr. Peterson.
Thank you, Amina, for that warm introduction. So I would like to first start off by addressing how did I even get interested in anesthesia first? See, I was in high school and my mom was like, hey, I think you should look at anesthesia. And it's interesting how she told me, because she's like, well, see, your dad got a procedure done on his heart. And the anesthesiologist was really helpful, informative, and I think that you should really consider that field. And, looking back on it, I'm like, I probably should have asked her, like, was something wrong with dad? Like, families tend not to share what's going on with them medically. But I'm like, wow, even before I got into college, I was like, okay, let me explore this, because I was interested in medicine. But then I became really curious about anesthesiology, hearing her mention that to me. And then I'm born and raised in Chicago, and I went to undergrad at Loyola Chicago. And I knew that I didn't want to go straight from undergrad to medical school. I really wanted to take some time off to explore to explore, do research, teach, which I did. I went to NIH. I did a research year, went to Ghana, did research there. And then I taught fourth graders for a year, which was just really a phenomenal experience. They say teaching helps you to be a better student, and that's absolutely true. So I went to medical school at Rush in Chicago, right across the street from Cook County. And Rush is the hospital for the White Sox. So that's like their claim to fame. And while I was at Rush, again, still curious about anesthesia, and really throughout my medical school rotations found that there was really no one organ system that I fell in love with, that there was no, aspect of medicine that was like, oh my gosh, And so what I liked when I requested my anesthesia elective, what I liked about it was that I was able to get a little bit of everything. I was able to see the results of what I was doing in real time. when it comes to supporting patients perioperatively, whether it be, giving them something to decrease their anxiety, to support their blood pressure. I liked how hands-on it was, how intimate it was. It's such a dynamic field. And so, thankfully, because I had anesthesia on my mind, I knew to request the rotation. Otherwise, I wouldn't have had the experience. I would have never known about it. So following all throughout medical school as well, I did do some research, to make myself competitive for residency. And to establish partnerships, mentorships. I did a away rotation at Mayo Clinic. I did research there for the summer. And I do strongly encourage doing some kind of research in order to establish that mentorship there. It helped me a great deal, the fact that I did, research in different places and was able to have mentors that I can call on who knew someone who could help me. I really appreciated that. So anyway, I did research throughout medical school, did research in undergrad. I went to WashU St. Louis for residency. So if you notice a theme, I stayed in the Midwest. I really wanted to get to know Chicago as a city very well, with my family being there. And then I didn't want to be too far, so hence St. Louis. And it was actually a really excellent program. My first year was my toughest year of residency. I was basically, throughout my whole training, I was pregnant. So first year, third year, and then during fellowship, pregnant. And then still managed to, do my step 1, step 2. So it was definitely a challenging journey, but one that I am grateful for because I could talk about it. And following residency, I stayed on at WashU to do Pediatric Anesthesia Fellowship. Following that, I did a pain fellowship at Boston Children's, which was 6 months of pediatric pain. And then I rotated at Beth Israel and Brigham Women's to do the adult pain piece. You have to do at least 6 months of adult pain in order to be board certified in pain. So I'm board certified in peds anesthesia and pain medicine. Following pain medicine fellowship, my first job out of training was at Texas Children's, and now I'm at Children's National. I've been there since 2018, directing the pain clinic there. And it's been my pleasure I met Aminat at Howard, and I meet a lot of the Howard medical students. And, there was a lot of questions that they posed to me in regards to like anesthesia. What is it? How do I get more experience? How do I get those mentorships? How do I make those connections? And so out of that, I decided to start a podcast. So it's called SEVO Sisters, SEVO, short for sevoflooring, SISTAS. And I created it for you all, really, a platform in which you can hear what the experiences are. What are the issues that are relevant to us? And what is it that we're grappling with? And what is it that we enjoy? You'll see that on my Twitter feed. I post the different episodes, and it just launched last month. So there's about 8 episodes on there. So I encourage you to engage. There's also a Facebook group because we really want you in the field. We know that racially concordant care is the best care. There's a lot of literature to support that. So I'm so glad that you're here and hearing the stories, and very much looking forward to hearing your questions. So I will now pass this along to the next panelist.
Thank you. Before we begin to have the next panelist answer the question, I would like to introduce Dr. John Patton, who was on call tonight, but he is still joining us. So thank you so much, Dr. Patton. He's a clinical assistant professor at UCLA Health, and we are glad to have you. So thank you for joining us tonight. And then Dr. Sumler, can you please answer the question about your journey through medicine, where you went to medical school, why you chose anesthesia, and where you are today?
Sure thing. First, I want to thank you all for inviting me to sit on this panel. But as was already stated, I'm Michelle Sumler. I'm an associate professor at Emory, and I'm originally from Virginia. And so that's where I started my educational journey. I went to undergrad at the University of Virginia, and then I attended medical school and residency at the Medical College of Virginia, which is also known as VCU. And I did my cardiothoracic fellowship at Johns Hopkins in Baltimore. So my journey is a little interesting because I was pretty sure the entire time that I was in medical school that I was going to be a dermatologist up until fourth year September, to be honest. And I was allowed to do a sub-I, believe it or not, in anesthesiology. Prior to that, I had very little exposure to anesthesia, aside from being on a surgery rotation and seeing an anesthesiologist at the head of the bed. But as soon as I did my rotation, I immediately fell in love with the profession and with the specialty. It really, in my opinion, brought together everything that I went to medical school for. There were very few things that I felt that I learned in medical school that I wouldn't use as an anesthesiologist. And so that was very intriguing. And I also have to admit, there was a bit of an adrenaline rush just being in the OR, particularly in high stakes, high acuity cases. We did a lot of trauma at my medical school. And so I definitely was very, very intrigued. As far as my professional journey, I guess I should also add, so I've been at Emory for 10 years now. And prior to that, I guess I'm kind of dating myself here, but prior to that, I worked at another institution for a year after I finished training and came to Emory 10 years ago. And one of the reasons that I was able to come to Emory is through mentorship, to be honest. I got a job that I didn't care for. And many of my mentors told me Emory was hiring and they thought it would be a great place for me. They had a lot of colleagues here that also could act as my mentors. And that all turned out to be very, very true. And so one big piece of advice I would tell everybody, regardless if you decide to go into anesthesia or not, hopefully you do, but even if you change your mind, the medical world is very small. It seems big, but it's small. And so cultivating relationships is very, very important. Finding people that are interested in mentoring is not as hard as you may think it is. I think sometimes as a medical student, you may feel like you're bothering an attending or resident, but the vast majority of the time, I think people are very, very interested in mentoring. I'm always excited when I meet a medical student that says they want to do anesthesiology. And so I would encourage you to cultivate those relationships. I definitely had multiple mentors that I still consider my mentors, even though I've been out for 12 years. But there are people that I still talk to regularly, that I still go to for advice. And when I'm having challenges or, questioning different things about my career, they are there to help out. I also made the decision to do a cardiac fellowship, similar to the adrenaline rush that I felt initially being in the OR with some everyday tasks. I really fell in love with the team atmosphere that's really notable in the cardiac ORs, and as well as the additional skill of being boarded in transesophageal echocardiography. So that's kind of my quick story. I don't know if I talked too long or not long enough. But I do encourage you all to get to know people, reach out to people, get advice, and hopefully you'll continue to maintain your interest in anesthesiology and all become one of my colleagues one day. So thank you.
Thank you so much, Dr. Sumler. Dr. Bradley, would you mind answering the question next, please?
Hey everybody, I am Stephen Bradley. I'm an anesthesiologist. I did my medical school training at Howard University College of Medicine, graduated back in 2014. I've always been interested in critical care. Well, since I was a medical student, I was interested in critical care, rounding in the ICU at Howard, so many incredible surgical attendings. Initially, I thought about becoming a trauma surgeon, but realized I really didn't like operating. Dr. Wendy Green, I think she's at Emory now, she told me about the options for critical care through anesthesia as well as internal medicine. And so my desire to go into anesthesia was from a desire to become an intensivist. I went to residency at the University of Chicago Medical Center. It is a critical care powerhouse, but I also swore into the Navy during residency. I have a kind of family legacy of service. My dad's retired Navy, my brother's in the Navy. So I had to fulfill that 4-year commitment after residency and was unable to do fellowship. I went to Virginia, where I practiced at a military hospital, deployed a couple times. And after 4 years, I've now returned to fellowship at the University of Chicago in critical care. And the importance of mentorship is huge. You know, being at Howard, there are so many incredible people, legacies, if you will, of Black physicians and Black people in healthcare. And, you know, it was a surgeon, a Black woman surgeon who really got the spark started and mentored me along the way. Dr. Bill McDade also was one of the few Black anesthesiologists I worked with during residency. And he took the time to pour into me and definitely made me part of, you know, the anesthesiologist that I am today. I've taken that as a mission to continue to give back. One of the reasons I'm here on this panel. I've also done a couple of things, whether it's mentorship through SNMA, whether it's virtual anesthesiology journal club that myself, Dr. Patton, and Dr. Adam Milam have started. You may have seen some emails or social media posts where every month we just get together with students interested in anesthesia and go over a couple of journal articles. Plug, since it is the ASA conference this weekend, there's going to be a live session at the conference on Monday afternoon. So that's part of giving back and being the mentor that I needed and that I took advantage of as I was in the process. What I love about anesthesia and specifically critical care is the fact that you can have such an impact in the lives of your patients. I love, especially being a Black man in medicine, that, you know, so often your patients haven't seen anybody that looks like me, and to be knowledgeable and confident and be able to provide outstanding care really helps change the narrative for those patients, as well as improving their healthcare and their life. So happy to be here and answer whatever questions you have. Finally, I do host the Black Doctors podcast. We have quite a few episodes featuring anesthesiologists, Dr. Betty, Dr. Milam's on an episode, and a couple of others. So every Monday is a new episode, just highlighting the life or pathway that a physician has taken. A couple episodes, you know, talking about burnout and other issues that we face routinely. So thank you so much for having us on, and hopefully you'll learn something. Good luck for those of you that are applying this season.
And Dr. Jessica Boateng, would you mind going next, please?
Of course. So I'm Jessica Boateng. I'm currently a pediatric anesthesia fellow at Upmc Children's Hospital of Pittsburgh. I'm originally from Detroit. I didn't think that I would actually always do anesthesia in medical school. I thought that I would do primary care, either family medicine or pediatrics. My undergrad degree was in nutrition, and I worked as a nutritionist for a couple years before medical school. As well, I went to MSU's DO school, and so they kind of try to get everyone to do primary care. It wasn't until the third year of my clinical rotations where I had my anesthesia rotation, maybe August or September. So it was an early rotation, and I just could not stop thinking about it. I think most people kind of blew off their anesthesia electives, but I was there all day from like 6 a.m. up until probably like 6 or 7 p.m. I just didn't want to leave the operating room. And so I kind of kept waiting for each rotation, thinking that I would like something better. I waited for family, I waited for peas, and I just couldn't stop thinking about my anesthesia rotation. And it was a mentor who was on that rotation, a woman physician, who told me, she's like, you just need to do anesthesia. And I kind of haven't looked back since then. My residency program was at the Detroit Medical Center. And I was the first Black chief resident in that program, which I found a bit interesting. Anesthesia is still kind of an old boys club in some ways. In Detroit, most of our patients are Black patients. However, not many of the physicians in Detroit are Black physicians. And so I initially felt a lot of guilt about not doing primary care, because primary care makes you think that you'll make a good impact on patients. But as Dr. Peterson mentioned, more and more literature is showing, especially in perioperative settings, that outcomes are better when their healthcare workers are looking like their patients. So especially in the OB setting, as well as pediatric anesthesia. And so I really felt good giving back to the community I came from, patients reaching out to me saying they're happy that I'm there. As far as the pediatric anesthesia component, I'm just graduated residency in June, and I started the pediatric anesthesia fellowship this August. So I'm a few months in, and I love it so much. I think I have less resentment towards pediatric patients. There is some continuity. Some patients or pediatric patients are chronic surgical patients, unfortunately. So I still get that continuity component that I wanted as a medical student from primary care. And I'm looking forward to seeing what I do next. I'm not sure if I'll do mixed practice or just pediatrics, but either way, I really like intra-op medicine as far as working with the surgical team. That's what kind of drew me to anesthesia. I like the autonomy that you get, but you're still a part of the team. I didn't want to necessarily be as involved in the surgery component, but still be a part of the perioperative setting.
Cool. Thank you so much for answering that. And Dr. Patton, can you also speak to your experience and your journey through medicine, what medical school you went to, your residency program, where you are now, and what you love the most about the field of anesthesia?
I appreciate it. Thanks for having me. I'm going to have to be super brief here. Also, trying not to violate any HIPAA violations or anything. I'm kind of in a nook of the ORs, but long story short, I had a non-traditional path to medicine, as many of us, can probably allude to as well. But after medical school, I should say I completed an MD, MBA, so I have a business degree as well. I went up to Stanford and did my residency. The reason why I chose anesthesia is because I was very much so interested in both surgery and medicine, conflicted actually. I came in thinking ortho, did a lot of ortho research. After doing my clerkships in third year, I started off with surgery because typically you kind of try and see if you can start with the ones that you're really interested in first. And so I got to start with surgery and ortho. Realized, all right, surgery's cool, but it wasn't really what I thought it would be for me. And I know it's only a month or so, 2 months, and it's kind of hard to like base your entire decision off of that, but I just didn't really feel like it was the perfect fit for me. So kept an open mind, really loved medicine. I liked rheumatology. I loved the mental gymnastics of medicine, critical thinking and whatnot. But after doing my rotation again, I just didn't feel like medicine was for me either. So I actually didn't know what I was going to do actually. Went into my MBA year, my first year between third and fourth year of med school. And I started shadowing anesthesiologists because a couple of buddies of mine that I went to school with said that they went into anesthesia and they're like, you have personality similar to us. We think you're going to like it. So try it out. I was like, all right. So my buddy actually, one of my buddies just texted me right now, who was kind of showing me the way, I should say. So I ended up doing some shadowing with anesthesia over the course of my MBA year. Turned out I really did like it. I recognized that anesthesiologists had a lot of the traits that I was looking for. A lot of procedures, a lot of medicine. We have to really have a keen understanding of pathophysiology. We could be anywhere in the entire health system, from outpatient to inpatient and all over the hospital, working with patients from all extremes of age, newborns all the way up to geriatric population and everyone in between. So it had a nice variety that I was looking for as well. So I really did enjoy it. Did a sub-I at Irvine where I went to med school, did a sub-away rotation at UCLA because I'm from LA, so I didn't have to spend the money to stay home or to I should say, do the sub-I to find housing. I just stayed home for that month. And here we are. So went up to Stanford, did a fellowship in regional anesthesia and acute pain medicine at Cedars-Sinai afterwards. Came down in the middle of the pandemic. Height of 2020, and then now just came up on my first year of being an assistant professor at UCLA, and I'm actually in the process of building out the regional anesthesia, dedicated regional anesthesia program here at Ronald Reagan, which is our main hospital. So I do a lot of leadership as well, like Dr. Bradley and others. I'm very involved with the local and national societies. I'll be at the ASA meeting this weekend, as I mentioned. I sit on various committees for the ASA, the CSA, which is the California Society of Anesthesiologists, and here at UCLA. So as an anesthesiologist, someone who has an MBA, I wanted to be able to lead and not just lead in the hospital, but also lead outside as well, doing advocacy work at the local and national level, and then also doing work out in the community, which this job really allows me to do. So that's why, and I'm happy to answer any questions if I can. And I may go in and out, just so you know.
No, thank you so much for being here, Dr. Patton. All right. So for the next question, not very many people are aware of the different subspecialties within the field of anesthesia. So for those who are currently fellows, and for those of you who are attendings right now, can you please tell us about what made you further specialize within the field of anesthesia, and what specifically made you choose what fellowship you chose? And we can start with, I guess, Dr. Boateng, since you just started your fellowship.
Okay. There's some logistical reasons, and then reasons that I'm obviously passionate about. My husband, who's also an anesthesia fellow, he's a chronic pain fellow. He's Canadian. So for some reason, one day we want to work in Canada. Anesthesia is 5 years there. And so doing a 4-year residency here and a 1-year fellowship gives us that opportunity down the line. And then I don't think it's necessary to do a fellowship right away, but to do pediatric anesthesia, especially at either a standalone children's hospital or in an academic setting, usually, you almost always have to do a fellowship. And I knew that was something that I was very interested in. To be honest, only a couple months in now, and I'm not even thinking about turning back to adult anesthesia. But I was a pediatric surgical patient myself as a kid. I like the setting. I like dealing with families and parents, that dynamic. It's just something that I really care about, and I feel like I can make a difference in.
Thank you so much for that. Dr. Peterson, would you mind answering what made you choose to further specialize within the field?
Sure. So my residency program from the very beginning made it clear to us that we want to establish a niche within anesthesiology. You want an area in which you say this is your own, because they've shared with us, and we see it now, that medicine is incredibly a lot more corporatized, right? It's a business. We always knew that hospitals need to make money, but even more so now, when you see who's running the hospitals, they're not medically trained. And so back when I was doing residency, they said that, hey, there are CRNAs, and they have a huge political lobby, and they are seeking to, practice independently. And if you're a generalist, somebody who, again, who business inclined and looking to maximize profits, may see you and see a CRNA and say, okay, well, you're both generalists, right? They try to put you in the same category, even though you're a physician and you've underwent extensive amount of training. And so everybody in my year, pretty much except for one person, ended up doing some kind of fellowship. Fellowships are only 1 year in anesthesia, so it's not like it's internal medicine or pediatrics where you're going to be spending 3 years. At the crossroads, when I was a CA2, that's when everybody, right, makes their decision if you're going to go private practice or if you're going to subspecialize. I said, well, I like peds and I like pain. And I ended up pursuing both. And I very much enjoy it. I get the longitudinal care aspect within pain. And then within peds, it's so dynamic, and there's such a wide range. You can get the preemies all the way up to the 25-year-old who has some kind of congenital issue. So it has the diversity. It has, children's hospitals are just nicer, warmer environments in general. People tend to be happy to be there, as far as happy to serve these families. And then when you see a kid riding past you in a little wagon, it just elevates your spirit too. So all that being said, when I do see people who are interested in anesthesia, I encourage them to identify a niche, whatever it is that you like, that you're going to own. And do you have to do a fellowship? No, you don't have to, but you should market yourself as far as this is what you are known for. This is what you like, whether that is difficult airways, being a patient advocate, safety, something, right? Something that you claim is yours that you want to stake a claim to. So yeah, I did both.
Thank you. And Dr. Sumler, I would ask for you to go next, but just before that, if anybody in the audience has a question, please put your questions in the chat. We'll love to hear from you and answer any questions that you would like to know from our amazing panelists. Dr. Sumler, can you please tell us why you decided to pursue a fellowship?
So I would echo everything that Dr. Peterson just said. All the residents here know that I am a huge advocate for fellowship training for the reasons that she already described. I think, encroachment, not just in anesthesia, but clearly it's far more apparent in our field. Some of the issues that are going on with mid-level providers and their desire to practice independently. So as she said, again, I don't want to be overly redundant. I think it's important to set yourself apart, and not that a general anesthesiologist is the same as an anesthetist. I'm not saying that at all, but I think, adding value to what you're able to offer, a department or an institution is very, very important. I kind of alluded earlier into why I went into cardiac. For me, it's very much an adrenaline rush. I like, how we really are pushing the limits as far as what we're able to do with patients in heart failure. We have a lot of mechanical assist devices that are constantly being updated and kind of changed. And then my love for transesophageal echo, I think also is something, when I kind of mentioned separating yourself from others, is a skill that I think is important, and being able to offer that to your patients and being able to collaborate with surgeons, and they actually value what you're saying, and kind of making treatment decisions in the OR based on what you see on the echo was really, really important to me. So if you ever meet me in person, or if you ever become a resident at Emory or see me at the ASA, I'm going to always tell people to do a fellowship. So just FYI. I had the conversation today with one of our chief residents who's choosing not to do a fellowship. But I'm a huge, huge believer in that, like I said, for the reasons that Dr. Peterson already mentioned.
Thank you so much. Dr. Bradley?
Yeah, who wouldn't want to be an ICU doc? Is definitely the best specialty or subspecialty of anesthesia. No, ICU is not for everybody. I really enjoyed getting to know patients, every aspect, every lab, every vital sign. I remember rounding at Howard in the ICU and just watching Dr. Saram at the time, or Dr. LaFall, not Dr. LaFall, Dr. Callender, and some of the other trauma surgeons, Dr. Green, and how they would just command the room and have a whole group of learners and stand there and just teach. And they were so smart. And I said, at some point, I want that to be me. I want to be able to pour into people's lives and have that personality, have that very deep and profound knowledge. I really enjoy the educational aspect that comes with critical care, what it adds to your career, being able to do maybe a week in the ICU. A lot of jobs, you have a week off and then do 2 weeks in the operating rooms. And that's a typical month of work for a lot of practices, mixed practice, anesthesiologist, intensivist. So that's what I really liked about the subspecialization. It just gives you something a little bit more, gives you some time outside of the operating room, depending on, where you practice. It could be useful to have that. Now, on the other side, I did work in the military. I've worked and moonlighted at several hospitals and civilian practice as a general anesthesiologist. Life is good. Life is good as a generalist. You make a lot of money. Not everybody has to do fellowship and do super complex cases. There's something to be said for just going to work, pushing some drugs, providing safe, effective care, supervising CRNAs, and then coming home and spend time with your family. The beauty of anesthesia is that this career has something for everybody, whatever aspect of medicine you like, whatever schedule you're trying to have, and almost whatever salary you want within reason. But for all those reasons, I highly recommend anesthesia, although, like I said, critical care is the best subspecialty.
Thank you so much, Dr. Bradley. And Dr. Patton, would you mind speaking to us about what your fellowship was and why did you decide to further specialize within the field of anesthesia?
Yeah, so totally agree with Dr. Bradley. Sorry I didn't catch what everyone else was saying. I'd step away from mine, but I do think that there is something for everyone. When I was in residency up north at Stanford, I actually spent a fair amount of time deciding if I wanted to pursue a fellowship or not. With my involvements, I was impressed upon by a number of individuals, especially coming from a place like Stanford, where It wasn't that we had to do fellowships or everyone was telling us to do fellowships, but the powers that be were definitely wanting to make sure that we further specialize, just to sort of make sure we had options down the road. And it sort of gives us a little bit of a safety net, I would say, for potential considerations or concerns that are unique to our field. Okay, perfect. And so for me, a lot of my mentors, one of my mentors, Ed Mariano, who Stephen knows at Stanford, some of you may know as well. He's one of the big names in regional anesthesia, and I worked a lot with him, was very impressed upon by him. I did really enjoy my regional rotation at Stanford. I also enjoyed my critical care rotation, but I didn't think critical care was going to be a great fit for me because of some of my other interests. So I was deciding between basically regional or going out and being a generalist. I sent in my application actually a couple of weeks before they were due. And I pretty much only looked at California programs because I wanted to stay in California. My wife and I have family in California, which is another consideration regionally where you'd like to end up at the end of the day. Certain programs may have certain, reach nationally, others may have more local reach. And so for me, I wanted to stay in California. Knowing it came from Stanford, I obviously had that on my CV, but I also wanted to do a fellowship in California just because it was easier for me and my family. We hadn't had a kid yet. We have a 16-month-old now, but we were also in the process of doing some family planning as well. So ended up applying to California programs, and I matched. I really enjoy regional because I think personally, and this may be my bias, regional anesthesia, as we've seen with COVID in particular, has really allowed a lot of unique opportunities for hospital systems, in that we can actually do a number of procedures that we maybe didn't think that we could do as outpatients, because the patients, outpatient procedures, because the patients are able to get through the procedure safely and they're able to have good pain control. And with ERAS protocols, which are enhanced recovery after surgery protocols, we try to optimize the patients before surgery, during surgery, and after. The patients are able to be discharged and not have to stay in the hospital. So it actually is a very good cost reducer for the hospital. It's a very good for customer satisfaction. Obviously, coming in with certain expectations about pain and being able to come out with not having much pain at all is something that's cool for us, because you get immediate gratification and you see results immediately after you block the nerves that would otherwise send signals up to the brain, where the patients are now obviously in agony. So there's a lot of cool opportunities there. And then, like I said, for me, I wanted to learn how to build a program. So I'm very much so interested in leadership. I want to climb the ranks through the health system, but also want to try and make a name for myself, in our space. And for me, I saw regional as an opportunity to do that. I serve on the committee for regional anesthesia, subcommittee for regional anesthesia for the ASA, and I'm also involved with some health disparities research, and primarily focusing on regional and acute pain right now, but also looking at health equity from many different lenses. But there's some other opportunities there that I found that I've been able to take advantage of, with my regional expertise as well too. So regional is great. It's fun. A lot of procedures. We get to work again with the laboring individuals on the OB floor, helping. I do OB anesthesia, but we also provide blocks for them. We do blocks for many number of surgeries, obviously, in the main OR. We also work and do things in the ICU, where Dr. Bradley is, for patients, let's say, who come in with rib fractures or traumas. We are able to help them breathe better, and so they have better pulmonary mechanics to potentially avoid having to be intubated. And then we also work with pediatrics as well, and do some things on the outpatient side if you want to go into chronic pain. That's a little bit different. But yeah, pain management, it's a lot of fun. I really enjoy the procedures, and I love being able to teach residents and medical students and fellows as well. So that's why I went into regional.
Thank you. And for this next question, anyone can just unmute themselves and answer the question. But now that we're in interview season, now that interview season is well underway, what do you believe are qualities that make a strong applicant for anesthesia? And anyone can answer.
Oh, I actually have a podcast episode about this, because this kept coming up over and over again about how can I make myself stand out. I will say that, number one, you don't want to walk into the room saying, "Oh gosh, I hope they take me. I hope I get an offer. I hope they see I'm worthy." Because obviously, if you don't have confidence in yourself, then you can't expect the program to either. So it helps to already knowing the answers to the basic questions, which is why anesthesia? Sometimes you might get a question like, how do you handle pressure? Tell me a time you've had to work in a team. Some people just want to know, tell me about yourself, right? So having a story about yourself that demonstrates how you arrived at this field. How is it what kind of experiences that you've had in the field that really resonated with you? What kind of life experiences have prepared you for this? So, some people say things like, well, I didn't come from a family of doctors. I'm like, well, that's great, because neither did your patients, right? You know how to now convey medical information in a way that a patient can understand. That's not a weakness, that's a strength. Or, I didn't come from a rich family. Neither did your patients. That is not a weakness, it's a strength. So it's looking at your experiences and not discounting that you have a rich experience, and realizing that the anesthesia is dynamic. It requires you to be hands-on. It requires you to take initiative, be able to make quick decisions on your feet, the ability to get people to trust in you in a short period of time. How have you demonstrated that? And providing some stories as to how that happened. And so just being ready for it, but being confident and acknowledging that you are worthy, you are valuable. How are you going to package that in a way that's digestible? And I always caution people, don't say you like anesthesia because you love physiology and pharmacology. Everybody and their mama says that. Everybody will yawn. It's boring. It's forgettable. You want to be the person that when they ask, what is your plan 5 years from now? You're like, I want to be the best, OB anesthesiologist in the world. You want to make your plans audacious. You want to be bold and be big, because that's what inspires people. That's what gets people to say, oh man, I want to help her. And I see how I can help her, because I know this OB person. I know somebody on the SOAP, which is the National, OB board. I know A, B, and C, and D. So you want to incite people to get excited to help you and see you on your journey. You don't want to say things like, well, I just want to do a good job and go home, because any program will say, well, you can do that anywhere. We want somebody who has dreams and big goals, and we want to help that person. So I'm going to see if I can, I'll look for the podcast episode and I'll link it in the chat here.
Thank you, Dr. Peterson. Does anyone else want to contribute to that question?
I can add, I think,
No.
of course, leadership skills, because once you're an anesthesiologist, you are a consultant. And so showing, specific examples of where you were a part of a team, you led a team and you brought people together, maybe even, in a sense of crisis or not, is very important during the interview process. And like you said, having confidence in yourself. I think once you get to the interview point, the confidence should be there because they're interviewing you. And so you should be asking questions about, why they're a good fit for you to be a resident there. And, trying to get to know the program to see if it's a fit both ways.
Thank you so much. So the next question we have is, how was the transition from being a medical student to an anesthesiology resident? And what are some of the things that you learned about yourself during the course of your training? And we can start with Dr. Bradley.
Yeah, so that transition is tough for a number of reasons. The things that you don't think about is when you merely start residency, you're probably transitioning to a new hospital system that you have to learn all over again. When you match into anesthesia, you're doing an intern year, whether it's in medicine, surgery, or a transitional year. That might be at the program that you matched up for residency, that might be at a different program altogether. And within that year, you're going to adjust to just being an intern and having that responsibility of being a physician and putting in orders and having that responsibility of patients' lives in your hands. And in that year, it's easy to forget about the end goal and get bogged down. And if general medicine is not your thing, you're going to probably do a fair amount of general medicine. And it's easy to lose sight of what you matched into. That all kind of starts to go away when you start anesthesia. Now, when you start anesthesiology residency or your CA 1 year, it's like drinking from a fire hose, because all of a sudden you're plunged into an entirely new situation and circumstance, and everything is moving 10 times as fast as it did on the medicine wards. And after that first year of anesthesia residency, you're going to feel pretty confident and comfortable. Well, then our friends in cardiac anesthesia are going to come and smack you in the face with another dose of reality. And you're like, whoa, how do I do a cardiac case? Dr. Patton and his friends are going to try and teach you nerve blocks. It's totally new and different. You're going to take care of the little babies. And the second year of residency or CA2 year, where you're starting to do all this subspecialty stuff, it's a whole bunch of more learning curves. But you'll see, over the course of your month or your rotation, you'll start to pick up those skills if you're perceptive. If you read, if you study and work hard, you'll see rapid progress with the things that you know, the things that you can do. The things you couldn't do before, you're not as nervous about now, and you know how to do it and take care of it. CA3 year, is kind of icing on the cake, where you're solidifying all of those skills and all those things that you learned, and you're really learning how to be that consultant, as was mentioned earlier. As anesthesiologists, we are consultants in anesthesia, and that's what separates us from a lot of other people that do provide anesthesia. We parlay with our surgical colleagues, our other physician colleagues, and we have to speak their language and remember all that medicine that you did way back when, because it's all relevant to the things that we do every day to keep our patients safe. Afterwards, you look back and you're like, man, that was a really rewarding experience. When you're in the middle of it, you may feel a little differently, but it's definitely worth it. I think as anybody who's practiced and pulled an attending paycheck on this panel will say, and there's job satisfaction and other stuff, but it's definitely worth it if you just push through.
Thank you. And I just want to ask, switch to the audience. We have one question from the audience, and it's, do you have any thoughts on how to best demonstrate interest and commitment to the field of anesthesia if you discovered it later in medical school? And anyone can jump in.
I can jump in here just because I decided on anesthesia fairly late. I was in an M3, like I mentioned, MS3 when I decided on anesthesia. And I, didn't know anything about anesthesia at all. I think one of the best things you can do if you're fortunate to have an anesthesia program at your institution is to find a mentor. Whether it be, an M4 who is applying anesthesia and is just waiting, for match to pick his, her, their brain, or if it's a faculty member, a resident that you can sort of, talk to figure out how to sort of navigate this space. One of the really nice things about anesthesia, and I came to realize it, and you'll realize it as you go about this process and you apply and interview, is that we're really laid back and chill. We're serious individuals because of what we do. It's like very high acuity. I was going to answer the question before by just talking about how we learn how to mitigate stress. Very high acuity, but you would never really, most anesthesiologists, you would never really know how stressed out they could possibly be, because we do a very good job hiding that. It's we definitely have very laid back, chill like environments, which is why I was very attracted to anesthesia. Even though we're dealing with some very serious, obviously humbling, we do some very humbling things, right? Like taking care of someone and making sure that they get through surgery safely is definitely not a small task, and we don't take it lightly. But having mentorship is really huge. And if you can find a sponsor, even better, someone who's obviously able to really like open some doors for you, make some calls, really put you out there. And I'll end by saying this. I think one of the most high yield things you can do, and I posted this to my Twitter actually, is this meeting that we have annually every single year. If you're an M3 or an M4, definitely if you're applying to anesthesia, I highly recommend you going to the meeting if you can afford to get down there. If you can get support from your medical school to go, that would be even better, or someone who can sponsor you to go, because we actually have a residency programs meet and greet on Saturday. And it's 2 hours, and literally every program in the entire country. I'm not sure how well attended it's going to be this year because we're still coming out of COVID, but usually pre-COVID, everyone in the entire country would go, and they would send either their program director, their APDs, their assistants, program directors, other faculty members, residents, fellows. Many people would be there representing their departments. And basically it's just literally like speed dating. You go around and you can learn as much as you can and figure out what you need to do. If you're early on, like M1, 2, 3, what you need to do to make yourself more competitive. If you're an M4, you can actually legitimately put a face to your name, your application, and that might be enough to have someone want to go back and pull your application out of the hat and give you an interview. So Definitely getting yourself out there. You know, we're not as stuffy as medicine or surgery, you know, not as intimidating, but getting yourself out there, meeting people and finding people like on this panel that you can sort of, you know, pick their, you know, people you can pick their brain is a good way to go about trying to find out what you need to do to be successful as an applicant.
Thank you. Dr. Sumler?
Yeah, I'm not going to talk long. I just wanted to add to what Dr. Patton said. As I stated, I decided September of my 4th year that I was doing anesthesiology. I was going to be a dermatologist. So it's definitely can be done regardless of how late you decide to do it. And I would echo everything that Dr. Patton said as far as finding mentorship. And he also mentioned something called sponsorship, which is not the same as mentorship. I'm not going to go into a really long story about it, but it's important to find people that are willing to advocate for you. And that's what a sponsor is. And sometimes that's very different and not always the same as someone who may mentor you. But I think generally speaking, I think most of the time faculty, when they hear someone's interested in anesthesia, we usually just kind of bring people into our world. And so I say express interest, find people, reach out to people. And it's definitely something that's doable.
Thank you so much. And we have another question from the audience. Christina wanted to know if someone was a C student in medical school, but can pass step 1 or 2, how can they redeem themselves in their 3rd and 4th year? And anyone can answer. Dr. Bradley?
So this person's a medical student?
Yes.
Or an undergraduate? You're saying medical school?
Yeah, medical school.
Medical school. Well, we didn't have we had a pass-fail system, so I'll let someone else answer this question. I was going to answer it as an undergrad because I have definitely some encouraging advice for undergrads, but not here. Sorry.
I think for medical school, you know, the grading is different based on your institution. It's a little unfair. Some institutions, literally, I think Yale does not give their students like less than a pass. It's like all high pass and honors. But there's other ways to stand out because, kind of like your question mentioned, the board exams are gonna kind of stick out. Although, you know, the step 1 is pass fail now. Your step 2 CK is gonna take on more meaning. There's research you can do. I think I posted in some of the comments different avenues for research. Even if your program or your school does not have an anesthesia department, you probably have a rotation set up somewhere. Even if it's a private group, talk to those docs about, hey, can I do some research? Most state societies have a newsletter where you can just, you know, sign up for the newsletter. It's probably free if you're a medical student. And then you'll probably have the opportunity to maybe write something in that newsletter. The American Society of Anesthesiologists also has programs where you can get involved and do research, the FAIR program as well. A lot of the stuff, if you Google opportunities, there's going to be ways to get involved, do research, do things that will set yourself apart.
I agree with Dr. Bradley. I think all of that he mentioned, whether it's research or different opportunities, the point is like once your application crosses someone's desk, it's not the first time they're seeing your name. And those opportunities really make a difference in that way too.
Great, thank you so much. And our last question from the audience is from Destiny. She said, my medical school does not have a 3rd year. Oh, sorry. My medical school does not have residents attached to our program. How would you recommend getting research experiences outside of our home institution? And anyone can jump in.
So I'll say this. I think it's funny. I'm on the admissions committee here or not admissions, sorry. We're on the recruitment committee here for our department. And they brought me on because I'm an outsider. So I have an outsider's perspective, not having trained here at UCLA or having spent a lot of time here. And one of the things that we are really having a lot of discussions about is what are the areas of emphasis? Like, what are the things that are most important on a person's application? Sorry, I'm thinking about person's application. If you're at an institution that does not have a anesthesia department, or you don't really have like a very robust research opportunity, that will be evident in a few different ways by obviously what you share. and then by our potentially knowledge of that institution. So no one's going to really hold it against you if you're at a place that doesn't really have like a very academic anesthesia department or an anesthesia department at all. The expectation is not going to be for you to now have, come in with a whole bunch of research. What I think is really important though is, what did you do with your time while you were in medical school? How productive were you? It's not just publishing, or doing research. Like, you have to do things that obviously meant something to you. And are we able to feel that through your application? If it looks like you're just putting things in your application to check boxes, that's really easy to see or maybe feel based off of how your application maybe is put together or looks. You can tell when someone really had an experience that was transformative. So I would recommend if it be doing outreach or getting involved with the medical school in various different ways, connecting with your local MAPS chapters or whatever you can do to really like have a connection to undergrads or high school kids or whatever it may be, to sort of help with pipeline programs. There are many different ways that you can show that you had a transformative experience that would suggest that you're someone that's going to come in and want to really help bring some value to a department. I'm not a huge researcher. I did do some research. I did some anesthesia research, but that's not why I was looked at, truthfully speaking. I don't think, at least when I applied to Stanford. I did a lot of stuff, through the SMA. I did a lot of stuff with our diversity committees. I did a lot of other things on campus when I was at Irvine. And I was able to speak to it in a way that showed that it was a really meaningful and transformative experience for me. And I think that was something that they wanted to hear and see and witness, that kind of like level of depth that I would be able to show with my involvement. And I think that's what you should be looking for. When you do something, don't just do it because you think that's what we want to hear, what we want to see. You want to actually involve yourself in activities that show longevity, meaning that you did it for a long period of time. If you found it late, fine. But if you started something earlier on and you stayed with it all the way through, that's going to really speak to you really being obviously passionate about that experience. And that passion is what people are looking for, more so than did you do research. I just want to put that out there, because we have this discussion about people who apply with research, whether they have X number of publications or no publications, or if they didn't have a research experience. And at the end of the day, we realize that there's a lot of bias and opportunities that may exist in some areas versus others. And so you have to be careful about how you weight things. What's more important to us is how passionate was that person about that experience, and was it transformative?
Thank you so much. Does anyone else have anything to add? Okay, so as we come to a close, can each of our panelists please give a one-line word of wisdom for our audience moving into their careers as future anesthesiologists? And we can start with Dr. Boateng.
I mean, I don't have any like quotes or anything, but really just stick with it. I mean, hard work, of course, to, I guess, echo Dr. Patton in a way. Research, a lot of these resume things are very important if you're passionate about them, but hard work really makes a difference, and it can trump a lot of these, I guess, things that people put on their resume just because. And so I missed out on a lot of things, family events and such these last few years, but it was totally worth it because I was like, building my career in the operating room. So you're not alone. There's a community out here to support you.
Thank you. Dr. Bradley?
I'll just say, imposter syndrome is real, and feeling that you're somewhere you're not supposed to be, it's real. The one thing I remind myself, I thought about this in med school, somebody dumber than you has done this before successfully. You could do it too.
Thank you so much. Dr. Patton, any final words?
Well, that last line makes me want to get up and go to battle with Dr. Bradley, I guess. I'll just say this, as I think those are two very good points. Just know you're exactly where you're supposed to be. Again, I mentioned that I was a non-traditional sort of medical student or trainee, and you come to realize that almost everyone is. Try not to compare yourself to others. Try to have a good understanding of situational awareness, where you kind of fit in time and space is very important in anesthesia. There's a certain time you want to take a step forward and offer help or ask questions. There's other times where you just have to understand there's certain things going on in the room that might not be the best time to do that. When you go into anesthesia, you're going to be one-on-one with a faculty member. So when you're interviewing people, you just want to show people that you're someone that they'd want to hang with, right? Like they'd want to be with. And you're not going to get along with everybody, and that's fine. Not every program is going to be for you, but when you find that one program that's going to make you a great consultant anesthesiologist, you're gonna go there and you're going to do really well. Just hang in there. It's tough, but at the end of the day, like Dr. Bradley and everyone has mentioned tonight, very rewarding on the other side. And honestly, I'm so happy that I chose anesthesia.
Great. Thank you so much to our amazing panelists. We appreciate your support of the SNMA and our membership. I encourage everyone to please follow us on Instagram at SNMA_official, on Twitter at SNMA, and like us on Facebook. But most importantly, if you're not a national member, please visit snma.org to sign up and get connected. Thank you for tuning in, and I look forward to seeing you all at the upcoming Sowing Seed webinar events. The next event is on October 28th at 8 p.m. Eastern. It's the Physical Medicine and Rehabilitation Sowing Seeds. After that, on November 2nd, also at 8 p.m., is Radiology, followed by Pathology on November 9th, also at 8 p.m. Thank you all so much for tuning in.